Ladies and gentlemen, first of all, I'd like to thank the organizing committee, Thailand Society of Reproductive Medicine, for inviting me to this very excellent virtual congress. On these occasions, I'd like to present about non-invasive preimplantation genetic testings, which is very interesting, and many study trying to investigate how the non-invasive approach in preimplantation genetic testing is favoring our clinical practice in IVF. I will focus on preimplantation genetics testing for aneuploidy as a non-invasive approach. As introductions, this is the very interesting paper come from Dagan Wells in 2020, emphasized that non-invasive preimplantation testing, or NIPGT, is the next revolution in reproductive genetics. It is because many recent discovery of DNA within the blastosal fluid of blastocyst and in span embryo culture media (SEM) has led to interest in the development of non-invasive methods of preimplantation genetic testing, or NIPGT. On the other hand, we know also that preimplantation genetic testing is increasingly used worldwide. It currently entails the use of invasive techniques such as polar body biopsy, blastomer biopsy, trophectoderm biopsy, which goes to obtain embryonic DNA with major technical limitation and also raising a lot of ethical issue. Evidence suggests that invasive PGT can lead to genetic misdiagnosis in the case of embryo mosaicism, and consequently to the selection of effective embryos for implantation or to the destructions of healthy embryos. This is becoming a very crucial point when we discussion about doing biopsy in healthy embryos, whether it will affect the quality of embryos or not. PGT requires embryo biopsy, which is invasive and also might be harmful to embryo. PGT is a methodology designed to assess the chromosomal complement of embryos that was generated during IVF procedures. And then the disadvantage of the PGT that requires biopsy of preimplantation human embryo, I've mentioned before, which can limit the clinical applicability of PGT due to invasiveness and complexity of the process. So many efforts have been made to develop non-invasive approach for PGT. This is the biggest challenge of PGT. The methodology requires the biopsy samples collected from the embryonic specimens, a procedure that entails not only technical but also economical challenge. In this regard, trophectoderm biopsy is considered generally safe, and it is the technique with the least impact on the embryos. We know that the trophectoderm is part of blastocyst, and then we should understand how trophectoderm also representing the chromosome of inner cell mass. This is also still questionable and challenging. The high degree of technical skill required to obtain the samples and the cost associated with the both of equipment like this, and laser biopsy, and then the operator training remain a bottleneck for wider implementation of PGT in all over the world. During the last few years, to reduce both laboratory workload and then potential detrimental effect of suboptimal biopsy, IVF and PGT laboratory has been investigating new sources of embryo-derived DNA. Indeed, the development of successful minimally or non-invasive methodology would also facilitate the implementation of PGT strategy in smaller IVF laboratory, including the remote areas, where researchers for competing and adequately thorough training on embryo biopsy are very limited. So this is for examples how we can compare. This is the invasive preimplantation genetic testing that we are doing on the cleavage embryos or blastocyst biopsy. And then for B and C, actually this is less invasive if we do the blastosynthesis or blastocell collapse biopsy. And then the very non-invasive method that we collect sperm culture media of cleavage embryo or blastocyst, and then we are performing genetic analysis using qPCR, NGS, array CGH, or SNP. So this is the possibility of biopsy embryo was done. In which stage of embryo? The first, this is the polar body biopsy. The only 30% of post-meiotic abnormalities undetected, so that's why we need double biopsy. Polar body only representing the maternal chromosome and it's not representing the paternal side. Then this is blastoma biopsy, 30 to 60% loss of implantation potential. However, PGTA can compensate the damage but not reach its potential. And the third is blastocyst biopsy, widely used in most of IVF clinics around the world. More DNA, fewer no result, fewer mosaic than compared to cleavage embryos, and then also reduced impact of embryo biopsy. And then the two last procedure is the most less invasive procedure. This blastocell fluid biopsy, and then this is sperm medium culture genetic analysis. The big question, how the concordance with trophectoderm biopsy in the both of technique, either blastocell biopsy or sperm culture media. So if we talk about the non-invasive embryo assessment, we can start from morphology, time-lapse morphokinetic, metabolomic analysis, and for the preimplantation genetic testing, the sperm culture media is actually included as the non-invasive preimplantation genetic testing. The next question is cell-free DNA in sperm embryo culture media as an alternative to embryo biopsy for PGT? Is it accurate or not? And how systematic review explain? Sperm culture media represent a possible sources of embryonic DNA for non-invasive PGT. However, before considering routine clinical use, methodology needs to be improved to increase detection of embryo DNA in sperm culture media, while also very important, we have to prevent contamination by exogenous and maternal DNA. So the identification of DNA origin is very important and necessary for improved reliability of sperm culture media preimplantation genetic testing. So this table 1 showing us how the sperm culture media samples in the selected studies. This is the studies. Mostly the subject is around the maximum is 42 subject, and then mostly they underwent ICSI procedures, and then the samples is coming from sperm culture media, and four study including also blastocell fluid, and mostly coming from fresh and a good embryo quality, and doing embryo manipulation before sperm culture media, such as assisted hatching and also blastocell biopsy. And they can identify that the release of cell-free DNA it's occurred between the incubation time 1 to up to 3 days, sometimes from 5 days. So the timing of collection also is quite vary between day 3 to day 5, even to day 6. And this is again, I think this is DNA quantification method, how we can quantify the cell-free DNA in span culture media. This is the DNA quantification. Concentration is in picogram to nanograms. Sometimes it's not so high, but some study they found until 100 nanogram per microliter. And then if they can identify until 20 to 100 copies of DNA. Yeah, this is also the same. Yeah, these two tables only explains to us that we can isolate cell-free DNA, and also we can quantify the cell-free DNA that coming from span culture media, even still in very low concentration. So what is our concern and main limitations of the span culture media based genetic analysis? This is the benefit, of course. This is non-invasiveness. They are very prominent. Easy, safe, and quick procedures, or embryos could be assessed. And then some concern is low cell-free DNA concentration, we know from the table before. And then how we can control of DNA contamination, and how can we convince the origin of cell-free DNA. And then the limitation, and also including the low sample size, mixed origin of embryos, partial collection and span culture volume, and then contamination. This is also the some consideration. So the next question is, non-invasive PGT is possible? Yes, many study already published, trying to explain how the span culture media and also blastosol fluid can be as a source of DNA derived from embryos that we can use for preimplantation genetic testing. You can see here the debate surrounding the efficacy of non-invasive PGTA. Yes, the ploidy concordance range between 2 to 95%. This is 1, 2, 3, 4, 5, 6 studies. Amplification rate is ranging from 11 to 100%, but mostly a very good amplification rate. The ploidy concordance is for the aneuploidy is around 80%. Also the euploid also around 84%. But one study is very bad. The concordance is only until 2%. And then if we talk about the origin of embryonic cDNA, cell-free DNA in culture media, there was widespread cell death in both of trophectoderm and ICMS evidence. It is happened because of fragmenting nucleus, which increased substantially by day 7. So that's why this is becoming very important issue, whether any contamination of cell-free DNA that are coming from embryo, this is coming from apoptosis or necrosis process. We know this is the apoptosis process. The DNA fragment size is multiples between 180 to 200 base pairs. And then the cellular features, cell shrinkage, membrane blabbing, chromatin condensation, and then how it's about how whenever necrosis are occurred. Necrosis is uncontrolled cell death induced by stress or injury. You can see the fragment size between small fragment and large fragment, cell swelling, increased permeability of the damaged brain, and then rapid depletion of ATP. So how the culture condition and outcomes of non-invasive PGTA? This is the previous study before. You can see almost they did all assisted hatching. They also can doing fresh embryo culture and some frozen tau embryos. Amplification rate mostly are good. Volume of media used for amplification is not so much. I think up to 20 microliter, and then diploidy concordance also very good, unless in two studies, only 30% and 2%. How the amplification method? Yeah, we can use whole genome amplification, and also we can use also the procedure multiple displacement amplification, or MDA. And different PGT platform can be used in our daily practice. The first is array CGH, the sample to report in 12 hours, and then the procedure is around more than 3 hours. And then the second thing is NGS, the next generation sequencing, which is faster, 60 minutes in difference, but sample to report also is same in 12 hours. And how the outcome? Yeah, this is all things almost the same which I have explained before. This is comprehensive chromosome screening, is the same. They use NGS, mostly they use NGS, and then they use the Malbec and MDA, double amplification, and it can be processed on fresh or frozen culture media. Amplification rate again is very good, unless one study. And then the ploidy concordance also is good, unless these two studies that only 2 and 30%. So what we are doing in Jakarta? So in our clinic in Jakarta, in RSCM hospital, we develop a PGT method to cell-free DNA in spent blastocyst culture media, and then 22 spent blastocyst media collected, then cell-free DNA isolated with using Illumina kit, and then the sample running by MySeq NGS in Illumina. How is the result? From 37 blastocyst stage embryos that we analyze, when culture media is from day 5, and then we are trying to corresponding with trophectoderm biopsy using the Illumina MySeq NGS. Yeah, this is the procedure to spend culture media. We aspirate the spent culture media from culture dish, and then we using declining from NGS Illumina, and then as a control we do the trophectoderm biopsy from expanded blastocyst in day 5. And then this is the result from non-invasive PGTA in Yasmin IVF clinic, in our clinic, 100% amplification rate. We can do all amplification procedure in all our spent blastocyst culture media. And then this is euploidy concordance, sensitivity 85%, aneuploidy concordance, specificity 70%, sex chromosome is 100% consistent. And then the total chromosome concordance is about 82%. It's not too bad. For the euploidy and also aneuploidy is more than 70%. And this is the figures. This is the result from trophectoderm biopsy. This is, for example, patient XX with monosomy 21, and then this is from spent blastocyst medium culture, exactly the same, monosomy 21 with XX. So this is 100% concordance. So what is the risk associated with non-invasive PGTA? The risk, of course, DNA contamination, I've explained before. They are coming from the human. Non-human, it means media, and also can come from maternal or paternal, and also lab personnel. And the consequences will reduce assay sensitivity, different culture system, condition across clinic, culture volume difference across clinic. So assay sensitivity will be impacted. So how should we mitigate this issue? The first, we should doing proper measure to prevent DNA contamination. Clinic may have to change the culture procedures, and then assay optimization by doing amplification plus comprehensive chromosomal screening method. And the last, could it become a clinical test, the non-invasive preimplantation genetic testing that based on spent culture media? Yeah, this is the ideal clinical non-invasive PGTA because robust, high amplification rate, with high sensitivity and specificity, reproducible, and also cost-effective. But outstanding issues that remaining, what is the source of embryonic DNA in culture media? This is we talk about the contaminant or contamination. Most studies offer a single center, so should work across the centers and need to identify the key parameters. So with minimal changes, it could work across the centers. And the last, as the take-home messages, the first, the effectiveness of new approach in non-invasive PGT has potential of developmental chromosomal screening applicability in clinical IVF. It is because of high accuracy and non-invasive and also cost-effective. However, the second, for accurate data interpretation and to avoid clinical misdiagnosis, the origin of extra-embryonic DNA must be confirmed, and the causes underlying discordance with the result from embryo biopsy specimen should be investigated. And the last, well-designed studies are required to determine how accurately cell-free DNA represent the genetic constitution of the whole embryo and to evaluate the clinical efficacy of these methods on pregnancy outcome. I think this is my presentation. Thank you very much for your kind attention. Thank you.